Hi everyone, and welcome to webinar session number 5. I really do hope that you are enjoying joining me every week for these sessions, as it's certainly a highlight of my week. Today we will be focusing on the pelvis and looking at some of the common postural challenge that you may come across following the seating assessment with your client. You will hear me say time and time again how important the pelvis is, as it's the foundation to good seated posture. It's fundamental that we understand our client's pelvis and whether any postural challenges that we find are correctable or whether the pelvis is fixed so that we can accommodate it or hopefully correct it in the seating prescription. So as always, get yourself comfortable and enjoy. Thank you, take care. Before we begin, let's quickly recap the important bony landmarks that we need to know about before we can fully understand the seating challenges of the body. Last session, we had a look at the anterior superior iliac spine, the ASIS, and to recap, those are located at the very front of the pelvis. Those bony prominences at the very front. There are also posterior superior iliac spines, the PSIS, and those are located at the back of the pelvis. Those bony prominences at the back of the pelvis. You can generally locate those on your clients by looking for the dimples at the lower back. Now, it's really useful to know where the ASIS and the PSIS are during the seating assessment, because when we get hands-on and palpate with consent or in best interest, of course, we can then get a better understanding of the pelvic movements and our clients' preferred pelvic positions. We also then need to assess to understand whether they are fixed or correctable. I don't know if you'd agree, but one of the most common postural challenges that we can come across in the seating world is a posterior pelvic tilt. Now, this is where the pelvis rolls backwards and the client goes into sacral sitting. During the objective assessment, when we get hands-on to palpate the bony landmarks at the pelvis and feel for movement, what we might find is that the ASISs are higher than the PSISs, which would indicate a posterior pelvic tilt. Posterior pelvic tilt can be associated with other postural challenges, so these are some of the things to look out for during the objective assessment. The client may present with an increased thoracic kyphosis, which we will cover in next week's webinar session. The client may have a tendency to slide forward in the seat, putting them at risk of falling out of the chair. That might be one of the problems reported by the support network. The client may also present with cervical hyperextension as they're trying to improve their functional visual field. Another thing to be mindful of when addressing our clients' pressure care needs is a potentially increased risk of pressure injury over the sacrum as they're going into that sacral sit-in, but also the apex of a kyphotic spine if that's one of the postural challenges they're presenting with. Your objective seating assessment will help you to determine the specific cause of your client's posterior pelvic tilt and guide you towards a solution, whether that's a seating prescription itself, if further input from other therapists, or even signposting for other medical interventions. Some of the intrinsic causes that could cause your client's posterior pelvic tilt include pelvic instability, limited hip flexion range of movement, so they're having to go into a posterior pelvic tilt to open up the hip angle. Maybe they have tight hamstrings or weak abdominal muscles, so they lack the strength to be able to hold their posture upright against gravity. But maybe fatigue may be causing it. If they have poor energy management and are fatiguing within the chair, gravity takes hold and they're having to slump and roll into that posterior pelvic tilt. The pelvis can also tilt forwards, otherwise known as an anterior pelvic tilt. And during the assessment, when you palpate for the bony landmarks, what you may find is that the ASISs are lower than the PSISs, indicating this anterior pelvic tilt. An anterior pelvic tilt can be associated with an increased lumbar lordosis, which we will cover in more detail in next week's webinar session when we look at the trunk. The client may also have difficulties with a functional reach if they present with an anterior tilt. So thinking holistically and about improving activities of daily living, it's really key that we try and find a solution for this anterior pelvic tilt in order to encourage independence. The intrinsic causes of an anterior tilt can include extensor patterns of activity, which can be affected by clients' mood or pain levels or response to external stimuli. It may be tight hip flexors pulling the pelvis anteriorly, tight paraspinal muscles, as mentioned, an increased lumbar lordosis, and even obesity as they go into that tilt to be able to reduce pressure on the abdomen for comfort reasons. Next, we have pelvic obliquity. During the objective assessment, when we palpate those bony landmarks, what we may find is that one ASIS is higher than the other ASIS. So, for example, in this image here, you can see that the right side of the pelvis is higher than the left side. This would indicate a pelvic obliquity. Pelvic obliquity is often associated with a pelvic rotation, which we will cover shortly. Pelvic obliquity can also be associated with scoliosis, as you saw in that image there, that there was a lean or a lateral flexion happening at the trunk too. And as mentioned, we will be looking at the spine in more detail in next week's webinar session. The client may also present with an increased risk of pressure injury over the ischial tuberosity, or the IT, on the lower side of the pelvis, because there'll be more weight distribution going through that particular point at the pelvis. Some of the intrinsic causes that we need to consider during the objective assessment include an asymmetrical trunk, and we would need to determine whether that was due to spinal deformity such as a scoliosis, maybe its weakness. So for example, in someone who has experienced a stroke, maybe they have weakness on one side of the body that's causing them to fall into that lateral flexion. Maybe it could be abnormal muscle tone. For example, someone with hypertonicity might be pulled into that lean, causing that pelvic obliquity. The client may also be going into pelvic obliquity due to hip trauma, dislocation or subluxation, and they are opening up that hip angle for comfort reasons. Same could go for limitations of hip range and movement, and they're being forced into that pelvic obliquity. And as always, we need to consider energy management, as fatigue can have a major impact on somebody's ability to achieve that upright and neutral sitting alignment. And finally, we have pelvic rotation, which during the objective assessment, we may find that one ASIS is more forward than the other ASIS. And as you can see in this image here, the right side of the pelvis is more forward than the left side of the pelvis. As we know, a pelvic rotation can often be associated with a pelvic obliquity, but it can also be associated with a spinal or a trunk rotation and wind sweeping deformity. We will look at wind sweeping in more detail in a future webinar session, but in brief, it's when the lower limbs are pulled or fall to one side and you have an external rotation and abduction of one hip and an internal rotation and adduction of the other hip, which then causes the pelvis to rotate forwards too. It's worth noting that an individual with a leg length discrepancy or hip problems may present with one leg appearing further forward than the other without a pelvic rotation, and that's why the objective assessment is so crucial. As pelvic obliquity and pelvic rotation are often closely linked, we do need to consider some of the same intrinsic causes, such as specific movements at the trunk, abnormal muscle tone or muscle weakness, asymmetries in hip range movement when comparing the left to the right, and even hip trauma, hip dislocation or subluxation, whereby the client is going into a pelvic rotation and a pelvic obliquity to open up the hip angle and take pressure away from the hip joint in order to reduce pain levels and maintain comfort. We do also need to consider wind sweeping, as already mentioned, as the lower limbs may be falling to one side or being pulled to one side, pulling that hip forward on one side. And another thing to think about is our wheelchair users who actually may be going into a pelvic rotation for functional reasons, such as unilateral foot propulsion of the wheelchair. And we need to be mindful in these cases to balance And I know it's a fine balance between achieving good posture but also encouraging function, as we don't want to be taking that independence away from them. We touched on the importance of accurate chair measurements during the objective assessment webinar session. This is something I'm going to continue to reiterate throughout the webinar series, as it's such a simple step that is often overlooked during the seating prescription and can actually have a significant impact on our client's ability to achieve good sitting posture. Now, we've addressed some of the intrinsic causes that we might determine during the seating assessment, but it's also important for us to consider the extrinsic factors. Even in clients who do not have damaged the body systems can still present with these pelvic postural challenges just because of the chair setup itself. So let's look at a posterior pelvic tilt from a different perspective and consider some of the extrinsic causes that could be causing this postural challenge. Maybe the seat height is too high or the footrest is too low, so the client is having to go into a posterior pelvic tilt just to be able to get their feet supported. It's natural for us to seek that feedback and stability through our feet. Maybe the seat depth is too long and the client is having to go into that posterior pelvic tilt, slide down the chair just to be able to flex their knees over the cushion and get their feet supported again. Maybe the armrests are too low, or the back angle is set inappropriately for the hip range of movement. If the client does not have good range of movement at the hip and the back angle doesn't accommodate that, then we will be forcing them into that posterior pelvic tilt to open up the hip angle. The same can be said for the use of the elevating leg rest. If we do not accommodate tight hamstrings, then we will be forcing the client into a posterior pelvic tilt if the leg rest is elevated. This is why it's crucial that we consider those critical angles at the hip and knee for sitting. We all have different spinal postures, and a client with a flat back posture may be forced into an anterior pelvic tilt if they are prescribed incorrect lumbar support. A client who presents with extensive patterns of activity or abnormal reflexes and muscle tone may also be impacted by incorrect seating prescription, as if the base is unstable or sloping, we can actually increase those extensive patterns of activity and increase the negative impact that they have on the body. Basic chair dimensions can have a negative impact on pelvic obliquity too. So for example, if the seat is too wide for the individual, they may go into that pelvic obliquity to seek that support and stability that they need for posture from both sides of the chair. Maybe the armrests are too high or too low, or they're set unequally, causing a lateral flexion or a lean at the trunk, which then of course impacts on pelvic obliquity. Maybe there's lack of support for clients who are presenting with trunk weakness or poor postural control. Pelvic rotation, as we know, is closely linked to pelvic obliquity, so can be significantly impacted by incorrect chair dimensions and setup too. For the same reasons, if the seat is too wide, the client may rotate within the base to seek that support and stability that they need from both sides of the chair. It may also be down to the incorrect back angle or lack of support at the pelvis, meaning that the client needs to open up that hip angle, as we know, causing that pelvic rotation. Please do get in touch if you have any questions about today's webinar session. I look forward to you joining me again next week. Thank you.